Good evening, everyone. Thank you all for joining this evening. I am Yolanda Johnson. I am the moderator for this evening, and I get to work with all of the wonderful folks from the Oncology Foundation of Maryland and DC. Before we get started on our just amazing presentation that's prepared for you this evening, I want to tell you a little bit about the Oncology Foundation of Maryland and DC. The Oncology Foundation of Maryland and DC, better known as OFMDC, is an organization composed of community volunteers who want to make a difference in cancer education. The mission of OFMDC is to bring together in a non-competing forum patients, patient advocates, doctors, and the research industry to provide education and information on available cancer resources. Tonight's presentation is a part of a learning series called Critical Conversations. And basically what we do is foster learning about cancer education from multiple perspectives and experts. I want to thank our sponsor, Medesco, the Maryland and DC Society of Clinical Oncology. As I said, tonight, we have an exciting topic. It's very unique because we have two people who are going to co-present for you. The name of tonight's topic is colorectal cancer, what patients need to know. First, we'll have Eden Stotsky-Himelfarb and Dr. Paul Celano, but I want to tell you a little bit about Eden first. Eden will share her personal journey of surviving colorectal cancer, complemented by the insights and expertise of Dr. Paul Celano. Little bit about Eden. In 1997, wow, Eden, I almost went all the way back on that one. But in 1997, at the young age of 26, Eden was diagnosed with stage 3 colorectal cancer. After experiencing increasing gastrointestinal distress since the age of 18, Eden's cancer journey inspired her to become an oncology patient navigator, supporting patients with colorectal cancer. And in 2009, she earned her nursing degree at Johns Hopkins. During her career, Eden has worked in a variety of adult outpatient oncology settings, focusing on gastrointestinal cancers, including colorectal, liver, pancreas, biliary, and abdominal sarcomas. Through her work, Eden has improved the outpatient oncology experience by providing evidence-based practices in education and resources, addressing common issues related to surgery, chemotherapy, and radiation therapy, and answering patient questions. Eden has served as the patient advocate on the National Comprehensive Cancer Network, colon, rectal, anal cancer panel, and on the NCCN Colorectal Cancer Quality Measure Subcommittee. She has authored a chapter in the American Cancer Society's complete guide to colorectal cancer entitled Taking Care of Personal Matters, Work, Insurance, and Money. Welcome, Eden. And I'm going to go ahead and introduce Dr. Celano as well before we get started. A little bit about our expert here tonight, Dr. Celano. Dr. Celano is the Herman and Walter Samuelson Medical Director of the Sandra and Malcolm Berman Cancer Institute at GBMC, the Greater Baltimore Medical Center. He holds a special interest in treating gynecologic, you know what, Dr. Celano, I'm going to leave that one to you. Gastrointestinal and breast malignancies. Advancing clinical trials is an area of passion for Dr. Celano, and he leads the Oncology Clinical Trial Program at GBMC. A native of Philadelphia, Dr. Celano did his undergraduate studies at the University of Pennsylvania. He completed his medical training at Mount Sinai School of Medicine in New York, where he had the opportunity to work with pioneers in the oncology field. Dr. Celano completed his fellowship in oncology at the Johns Hopkins University School of Medicine and served on the full-time faculty prior to joining GBMC. He moved to GBMC. His move to GBMC was spawned by his passion for taking care of patients. Known as a compassionate and skilled physician, Dr. Celano shares, I like to help people through the process of cancer and also apply the things that I have learned. At the national level, Dr. Celano has served as the chair of the Affiliate Council and as a member of the Clinical Practice Committee of the American Society of Clinical Oncologists. A little fun fact about Dr. Celano. He was a native of Philadelphia and he was his high school class valedictorian. Wow. Well, brag on all of us, why don't you? Dr. Celano and his wife are celebrating their 42nd wedding anniversary this year. He shares with pride that his wife is a pharmacist at Johns Hopkins who built the specialty pharmacy for HIV care from the ground up. They have one son and a grandson. Dr. Celano laughs when sharing that his son chose to become a lawyer. He wanted nothing to do with medicine, Dr. Celano says. So as you see, we have two folks here tonight that are going to bring you a very compelling presentation. We have Eden, who has lived experiences. What better way to bring you someone who has experienced colorectal cancer? And then we have our expert as well, our physician, Dr. Celano. So I am going to turn the floor over to both of them.
I think they're both on mute.
Yeah, Dr. Celano and Eden, you have to unmute.
Yeah.
There you go. Oh, Dr. Celano, I think you're still muted. There we go. Nope. We have to hit unmute one more time. Perfect.
There you go.
Okay.
Yeah, perfect.
Just let me know when you'd like me to share the slides.
Well, why don't we just start? Hello.
Yeah.
Welcome, everyone. We're
Hey,
so
everyone.
glad to present this evening. I'm hoping this will be very informative.
Would you like me to share the slides?
Yes, please, yes,
Yes.
please share the
Okay.
slides.
Yep.
Yeah, I'm sorry. There we go. Okay.
Nope.
Topic tonight is colorectal cancer, what patients need to know, or at least some of what patients need to know. Next slide, please. Okay, just to remind everyone, March is Colorectal Cancer Awareness Month. That's why we're talking about it this evening, but so spread the word. Next slide. Just in the critical discussions, I have a number of topics that I want to cover this evening. And we'll go through these, the statistics, the risk factors, what exactly is colorectal cancer, screening, signs and symptoms, the diagnosis, genetics, cancer stages, something about surgery, the treatments of cancer, and then Eden will provide us with her personal story and survivorship and her other insights. Okay, next slide, please. I always like to start with what I'm going to talk about, and I'm going to end what I'm going to talk about. But the colorectal cancer is a growth of cells that form in the lower end of the digestive tract, and removing polyps can prevent cancer. Symptoms may include blood in the stool, abdominal discomfort, change in bowel habits. Colorectal cancer treatments depend on the size, the location, the genetic analysis, stage of the cancer. The treatments these days can include lots of things, including surgery, chemotherapy, immunotherapy, targeted therapy, radiation. And it's also important to hear that genetics and immunology are playing an increasing role in the diagnosis and management of patients with colorectal cancer. Slide. This is again, a summary slide of signs and symptoms of the signs where many people experience those symptoms, which is why it's important to do screening, which I'll talk about more. But these symptoms, which we should never ignore, are change in bowel habits, rectal bleeding, persistent abdominal pain, or feeling like you're not completely emptying. The early detection is key. The risk of 30% of cancers can be reduced. The risk of 30% of the cancers can be reduced by changing your diet and lifestyles, and I'll talk about that. The risk for colorectal cancer clearly increases with age, although we're finding that younger people are now getting colorectal cancer. And we'll talk more about these lifestyle changes. Next slide, please. Okay, so colon cancer is a disease which is malignant cells that form in the tissues of the colon. This is just a picture. Next slide. And the colon, you'll hear colon is divided into a couple of sections, and this often determines surgical management and also increasingly biology of the malignancy. Next slide, please. Next. Okay. So next, back up one. Okay. Cancer statistics, there's 2 million cancers are diagnosed in the United States each year. The cancer mortality has declined. Sorry, can you hear me? Okay. Right. Cancer mortality has declined continuously over the last 30 years due to reductions in smoking, improvements in treatment, early detection. However, progress is still jeopardized in many common cancers like breast, prostate, pancreatic cancers. Colorectal cancer has moved up from the fourth leading cause of cancer, moved up to the fourth leading cause of cancer death in people younger than 50. And it's in the late 1990s, the first in men and second in women after breast. Next slide, please. This is the statistics from the American Cancer Society, and the top part is estimated new cases, and the bottom is deaths. And you can see that colorectal cancer in men and women are about equal and represent a fairly significant amount of cancers that are diagnosed in the US each year. Prostate obviously being more dominant in men and breast in women. Unfortunately, lung cancer continues to be a major problem. And then on the bottom, you can see in terms of estimated deaths from these diseases, colorectal cancer being third highest, and in men and fourth in women. And unfortunately, lung cancer continues to be a dominant lethal cancer. Next slide. So are you at risk for colon cancer? Being older, your risk definitely increases with age. Apparently, the older we get, the more stuff happens to us. And so it's important to recognize that as we get older. Personal and family history, having a parent, sibling, child with colon cancer definitely increases our risk independent of the genetic factor. So having another family member with something really should key us into getting better screening. Race, African American men and women are clearly at higher risk. Inflammatory bowel disease, such as ulcerative colitis, is also a risk factor. And other things which we can do a bit about, not being physically active, our diet increase higher in red meats or processed meats is definitely a risk factor. Being overweight, overuse of alcohol, and tobacco use. No one's actually figured out a good thing that tobacco does. Okay, next slide, please. Next, yeah. Okay, so this is just the incidence of colon cancer by age, and you can just see that as we age, that it's clearly a disease of aging. Next slide, please. Okay, next, and then, but there is this rising colon cancer rates in young adults. And born in 1950, it was about 3 in 1 million, and it's increased to 5 in 1 million. So there's definitely something going on here. No one's exactly sure why this is, whether it has to do with diet, etc. Next slide, please. And then this is just kind of dividing things by things that we can change and things that we can't. I mean, there's hereditary colon cancer and family history. We can't do much about that other than we can screen for it. We have other factors such as using like things like aspirin or menopausal hormone therapy or statin use actually can reduce that risk. And ethnicity, male gender, diabetes are obviously positive or negative risk factors. And then on the right side, modifiable risk factors such as smoking, meat, high alcohol intake, increased obesity are clearly risk factors. And then things that we can help to reduce is just basically the opposite of that: physical activity, increased fiber, fish intake, vitamins, calcium supplementation. Okay, next slide, please. And then, there's types of genetics. I always like to throw this slide into because genetics gets confused a bit. There's what are called germline genetics, which are normal cells that are tested for genetic mutations that may be inherited from your families or transmitted to your children. And then there's the somatic genetics, which is genetic changes that occur really exclusively within the cancer itself. So they're kind of unique to the person's cancer and aren't necessarily transmitted, although there are some which kind of can overlap this a bit. Next slide. And then this is, again, a very busy slide, but just to say that there are many, many genetic risks for cancer. Increasingly, genetics has become such an important role in trying to make increase better screening, better diagnosis, and better treatments. Example, breast cancer with the BRCA gene is an example. So there are lots, and then you can see I have an arrow at the colorectal cancer, the so-called Lynch syndrome, and the familial polyposis are key ones that put people at higher risk for colorectal cancer. Next slide, please. And then within colon cancer, like how common is this, in terms of these hereditary things? In the blue there, that's just means sporadic cases, mean they have no identifiable genetic risk. So the vast majority, 75%, are not anything genetic related, although it's common across the population. So not having a genetic problem doesn't mean you can't get colon cancer. It just means you're at a particularly higher risk. But there are, in terms of there are cases which are familial, and that's why your family matters. It always matters in terms of health and whether it's cancer or heart disease, diabetes. And so there is that increased risk. And then there's this subset of people, this Lynch syndrome, hereditary non-polyposis colon cancer, or familial adenomatous polyposis, which are clearly genetic syndromes that put people at much higher risk. And so next slide, please. Okay, and then how high is that? So in the orange or whatever color that is, that's for the Lynch syndrome, and the greenish is the general population. So if you look at patients who have Lynch syndrome, they have a 80% chance of developing colorectal cancer as opposed to the general population, which is 5%. There's also other cancers that are at risk, particularly endometrial cancer in women, as well as ovarian cancer. So it's a much higher risk in those patients, as well as stomach cancers. So that having those syndromes are important to know because of these much higher risks in terms of screening and being aware. Next slide, please. And so this is a real busy slide. I probably don't want to go through it too detailed, but there's a difference between a Lynch syndrome and familial polyposis. So probably the biggest thing is clinically is that patients with polyposis have lots of polyps, whereas with Lynch syndrome they don't. But Lynch is much more common. Again, they probably age onset is not quite as high as the familial polyposis, but it's still pretty significant. Okay, next slide, please. And then who should consider being tested? Obviously, family history matters. So if you have any degree of family members, that is certainly something that should be brought to the attention of your physicians. There are genetics counselors, Johns Hopkins has wonderful genetics counseling, as does GBMC, and so do many hospitals. Then the personal history, if you have more than one cancer that's kind of linked to it, you have a uterine cancer and endometrial cancer, that's obviously a huge tip-off. Or you have it at a younger age, under 50, that's also a huge tip-off. So young ages or one or more cancers in the same person is a pretty good sign for that. But there are specific tests that can test for this to know for sure, is this something by happenstance or actually genetics. Next slide, please. And then just to kind of talk about screening quickly, screening makes a difference. It's definitely reduced cancer rates, risks of death rates. And that's the whole object, is screening doesn't prevent cancer, but it finds it early so that you can do more about it. And in terms of whether it's breast cancer, colorectal cancer, cervical cancer, since so many people will develop cancer in their lifetime, it's very important to have these screenings. And there are many, upwards of 16 million people who are cancer survivors in the US, and that's growing. That was from 2019. I'm sure the number's a few million higher. Okay, next slide, please. And then in terms of screening, there's kind of several tests, and not to get too much into the weeds of there's these stool-based tests, and there are basically direct visualization, meaning sigmoidoscopies or colonoscopies. There's the so-called virtual colonoscopy where a CAT scan's done. But I think it's important to see that whether it's a stool-based test or it's a CAT scan, virtual colonoscopy, if there's ever any question on any of those tests, person needs to go through a colonoscopy, because the diagnosis of cancers can only be made on a biopsy. Next slide. And the options are, I think, I guess I just said that there's either a one-step test where you just go right ahead and have the colonoscopy done, or the two-step test where you're actually having either the occult or the so-called Cologuard tests, the DNA tests, but they will also lead to another to a direct visualization, because it's important to determine what that is. And if there's any question about those tests, or some question, is it really negative and all that, you should definitely go through that. Next slide, please. Okay. And so recently they changed, last few years, they changed. It used to be 50 was the time to do screening for colon cancer. It's now 45. So that's the latest thing. So age 45, everyone should be considered for screening for colorectal cancer. So that's really important. There's still upwards of a third or maybe even higher than that, depends on which part of the country you're in, which are not getting screened. So it's very, very important. And I've been seeing a few cases of patients that never had screening that showed up with widely metastatic disease. It's a kind of a tragedy that they could have been checked sooner. But next slide, please. Cancer, and the reason we do screening is it actually takes quite a while for colon cancers to develop. If you look on the bottom, there is initiation starts very long ago, 30 or 40 years, and then it may develop into a small polyp, or maybe a larger polyp, or even an adenoma. So it takes a while to develop these cancers, and so that's the window of time that we need to look at to find these polyps, these things early, to then make to treat the patient. Often these polyps can be treated with just endoscopically. I mean, and there's more and more interesting visual tests that are being done through that video-based, some artificial intelligence type stuff it's in the horizon. So next slide, please. And so this is just general recommendation. Anyone between ages 45 and 75 should get screened. It doesn't, I mean, honestly, any test is better than no test, of course. As you get older, even though we're saying colon cancer develops older, usually if people have clean screening tests by the age 75, it's not so, critical, because at that point, you would have either developed these pre-malignant areas or not. But again, no hard and fast rules, especially given the length of time so many people are living these days. That certainly wouldn't discourage an 80-year-old from having a screen test if they felt they needed it. Usually, though, over age 85 is usually not recommended. So, next slide, please. And okay, and we talked earlier about the changes in symptoms that people can have related to the cancers. And next slide here. And then again, symptoms of advancing cancer, change in bowel habits, feeling to have to move your bowels, or abdominal cramping, gas, weakness, unexplained weight loss, all these things. Again, never to avoid the warning signs. And I think the general rule is, if you're concerned about it, then talk with your doctor and have them check it out. If you just had a colonoscopy last year, maybe it's not so important, but maybe if you hadn't, it's time to check it out and see. Okay, next slide, please. And then this is again just kind of what people do in terms of, they come in with some symptom or some blood test like anemia, low red count meaning, and then it does lead to testing to see. So, not everybody necessarily needs a colonoscopy right away, but it should be part of like a thought process in terms of, is this something that should get, checked out? Okay, next slide. Now, understanding the stages of colon cancer and their treatment. Next thing here. And then, whenever we talk about cancers, we talk about what it is it cancer or not, and then the stage generally means where it is. So the stages of colon cancer, stage 0 is really the polyp, and stage 1, we like to get these things stage 1, and stage 0, stage 1. Stage 2 is when it's kind of pushing through into the wall. Stage 3 is when it's through the wall, and stage 4 is when it's spread to other organs beyond the colon. Next slide. And it's important to see that people have really now kind of honed in, and Johns Hopkins has obviously been a leader in looking at gene mutations in colon cancer and methylation. And so there are very characteristic things which are now being translated into different testings and different even therapies. Next slide, please. And so this colon cancer, can metastasize, and metastasis means when a cancer leaves its organ of origin, like the colon here, and spreads. And I always think of it as a crazy thing about cancers, that they can go to other places in our bodies, and they can spread either within the abdomen or to the liver commonly, or lungs, or bones, or brain. So it can be quite extensive in patients, and sometimes quite silent in their development. Next slide, please. And then this is just survival rates for colon cancer. Why do we want to find these things early? Is obviously stage 1 is when, instead of polyps, it's even better. Survival is really good. Stage 1 is obviously better than stage 2, 3, or 4. Those numbers have improved over time, but it's still important that staging matters in terms of what this means to any individual. I would say, like, these are population statistics, what happens to thousands of people, not necessarily what would happen to any individual, in terms of time. But it gives people at least a general guide of what the generalities are. Okay. Next slide there. And then, how will my colon cancer be treated? And it really does depend here. Next slide, please. This is kind of a real quick summary of it. Surgery, stage 0 is, often stage 0 or 1 is either surgery or even sometimes polypectomy can be removed. Stage 2 is also surgery, sometimes chemotherapy. I'm going to explain a little bit better about what's sort of changing in that field. The genetics have changed that as things for surgery for stage 3. And stage 4, often sometimes surgery is done or not done, and then other more extensive systemic therapies are used to address spread colon cancer. Okay, next slide, please. Okay, robotic surgery has improved the outcome of many patients with colon cancer. This is like, it's amazing the surgeries that are able to be done, where they don't have to do the pull open procedures. They can do less scarring, less pain, quicker recovery, and the surgical outcomes are identical to the more extensive open procedures, which would be not. And it's not to say open procedures are never done. They sometimes need to be done depending on circumstances, but often they can be done in a more limited way. Next slide, please. And then just, it's just, again, it's very basic, just there's a cancer there. They usually, in the simplest situation, they remove the cancer and the surrounding lymph nodes, and then they're able to reconnect things, and they're good to go. But there's much other situations that may require more extensive other surgeries, like colostomies and other things. Next slide, please. And then chemotherapy, when is chemotherapy used at different times during treatments? Sometimes we do it, it's called neoadjuvantly, in other words, preoperatively before the surgery is done, sometimes in combination with radiation. Adjuvant chemotherapy means treatment given after the surgery, the goal being to kill any cancer cells that might be left behind. And then there's more systemic therapy with more advanced cancers when they've spread elsewhere to other organs, such as the lungs or liver, etc. Next slide. Okay. This is a very quick review of all the things that have happened in treatment of colon cancer in the last, whatever it is, 40, 50 years, I guess it is almost. And, starting back in the 60s, really almost the 50s, to 5-fluorouracil, and then the development. And really not much happened between 1962 and 96, honestly. And then we saw a resurgence of some of the newer chemotherapy drugs, the capecitabine oral drug, and then what's happened in the last 20 years have been more targeted therapies affecting the drugs like bevacizumab, affecting blood vessel or the certain growth factor areas. And then recently, we've seen the drugs like pembrolizumab or nivolumab treating for immunotherapy, and some more other drugs which are more directed toward certain genetic changes that appear. And this isn't even a complete list. There's a lot of other drugs here, but it just gives some idea what's been happening in the last so many years. Next slide. And then, so all these drugs work differently. Chemotherapy is, standard, what I call standard or traditional chemotherapy affects dividing cells, and they tend to be pretty non-specific. They can cause a lot of off-target things we don't want to ever happen, like hair loss or intestinal damage or nausea, effects on our blood counts. And whereas targeted therapies are directed more at specific targets that are on the cancer cell itself. It's not to say they don't have their own issues too, such as causing rashes or diarrhea or liver issues, but they certainly, as a class of drug, are much better tolerated than chemotherapy. And then the other class is the immunotherapy drugs, which are literally turning our immune system to effective for treating the cancers. Next slide. So we talked about this earlier, the germline testing and somatic testing. So what I'm going to talk about here is the somatic testing, the things that have mutations that have occurred on the cancer cell itself. The next slide, please. Okay, and then there's just a whole, the genetics. I've had the privilege, honestly, of going through, of just hearing people talk about genetics, and then actually now it's been applied to people, but all of these different markers that are available now to look at it, and it's just, this list just keeps growing. The science into this has just been absolutely amazing. Next slide. And then, we know that even people's cancers, like the right-sided cancers, tend to have certain genetic changes, whereas the left-sided cancers of the colon have other kinds of genetic changes, and affects, prognosis and treatment. So it's very interesting. Next slide again. And then these are, this is more, in terms of other genetic changes that occur within cancer cells, and certain other things that are utilized to help treat cancers, such as up on the far right, the so-called checkpoint inhibitors that are immunotherapies that can be used to treat certain cancers. Next slide. To talk briefly about rectal cancer, is kind of a special cancer for several reasons. That how it's treated. Rectal cancer is something that's at the last part of the colon, but not all the way out. And it has a unique thing because it's generally been treated with radiation and chemotherapy, so-called total treatment for rectal cancer. Next slide, please. And this is the total neoadjuvant treatment. So it's given prior to the surgery, so people can go through radiation chemotherapy and have then their surgery, and it increases, it gives much better survival, reduces chances of spread. So that's been a big advance in the treatment of rectal cancer. Next slide. And then immunotherapy has also played a great role. Next slide. And, again, traditional chemotherapy, radiation, drugs, it just kills everything, it kills everything, but it's selective in treating cancer cells, but obviously healthy cells are affected. But immunotherapy unleashes a person's own immune system to treat cancer cells. Next slide, please. And, there's lots of opportunities in terms of and we've seen this happen. It's amazing. This is the last 5 years or so, someone longer survival, better response rates, lower adverse effects, better quality of life. I mean, there's still challenges regarding who's the best patient and what's the duration of treatment and how do we monitor this. And there are also immune-related adverse side effects that also need to be managed. Next slide. And then how these things work. I mean, it's just, again, for the longest time, people tried vaccines to try to stimulate the immune system. What people figured out, and someone won a Nobel Prize, and I'm blocking on the person's name, who just won it a few years back, but figured out that the problem with cancer was it had this stop signal, that it was stopping the immune system from working against the cancer. And if they could get rid of that stop signal or inhibit it, you could then treat cancer. Amazing concept. And so it actually, that's how these drugs work. They do stimulate the immune system to rev up against cancer cells. Causes other off-target problems, but by and large, pretty effective. Next slide, please. And then this is from about rectal cancer. What brought this up is because, and this was reported a few years ago, really, on that you can see that there was a neoadjuvant trial out of New York using one of the immunotherapy drugs, and really had almost 100%, I say almost, but they actually reported 100% response rate in patients who had the tumors that had this mismatch repair deficiency. It's just unheard of with good tolerance. Okay, next slide, please. And so, this is a busy slide, but it just kind of maps out, like, how, when we look at patients with cancer, we're not only looking at that they have cancer and the stage of their cancer, but also what are the genetics of them, what are the genetics of the cancer, because that really does determine how we're going to treat patients. So next, I can tell you, when I was starting my training, it was everybody got the same thing almost. So it was like, and then, this is now, like, in terms of we talked about preventative cancers. Like, we know patients with stage 2 cancer that not everybody relapses. We saw those survival curves, and not everybody fails, but some people do. So you would want to give the treatment to the people that would benefit from it, and not to the people that won't benefit from it. But with just chemotherapy, you kind of were stuck. You're kind of treating everybody, and that was not, obviously that is not ideal. And next slide. Yeah. So what people are now using the DNA in the blood, the so-called circulating tumor DNA, to help manage patients who have had surgery for colon cancer. There's a clinical trial that's ongoing for adjuvant chemotherapy for this is stage 3, but actually there's one for stage 2 as well. Next slide, please. Okay, and basically the idea here is that within the cancer cells that the circulating tumor DNA will show up in the blood, and you can actually analyze it in a blood test and know is there circulating tumor DNA or not there. The next slide. And from that, you can help to know, is this person at higher risk or not? Now, there's a lot of studies that are looking at this issue, and I won't say it's like completely ready for prime time, but I think it's getting there in terms of that we're able to now help to know, is that person at risk, and is there something they require more treatment or different treatment? So next slide. I think I have this one of the last ones. And so we can look at, we talk about neoadjuvant, did they really respond? Do they have any disease left behind? Can we, when monitoring them for recurrence, for treatment response and monitoring? We used to have we still do have a test called a CEA, which is very crude and really very non-specific. Next slide, please. And then this was this particular study that, in the study, if the person doesn't have any circulating tumor DNA, so some people are treated, the other people are watched, and people who have circulating tumor DNA, there's a comparison between 2 different kinds of chemotherapy. But it's the beginnings of refining how we give treatments to people and better monitor and manage people. So trying to give treatment to the people who need it, not to people who don't, and avoid side effects and problems. Next slide. And so that's a big whirlwind of things, and I hope this is like, and basically it's the same slide, that there's a growth of cancer cells, that are removing polyps, and currently looking at things over at age 45 is very important. The symptoms of colon cancer, the treatments depend on the stage and size and location and genetic analysis. That treatments can include all kinds of things anymore. It's just not surgery or chemotherapy or radiation. It's immunotherapy and targeted therapy, which are including almost hundreds of things at this point. And genetics and immunology continue to play an increasing role. And so I think with that, I think that's the end of my talk part of this. And I appreciate everyone's time in listening to this. I'm glad to answer questions. I know that Eden will give it her talk. Thank you. Thank you.
Thank you,
Dr.
Dr. Celano. Looks like we have one question. Go ahead, Mercer.
Can you hear me?
Yes.
And we are using circular DNA testing in our practice. So if you do get a positive circulating DNA test in your practice, do you automatically do a PET or a CT scan?
Pretty much, yes. I mean, particularly if it went from negative to positive, generally, yes. I mean, it depends on when we did a scan last and all that. But yeah, you like to be able to visualize something, because sometimes, and talk about this at all, but sometimes patients will show up with a isolated metastasis, like a liver metastasis, that may benefit from surgery.
And sure. So my question is, so you have a positive circulating DNA test, but you don't have any patients asymptomatic. Do you have had any problem with insurance paying for these imaging studies?
Generally not, generally not. I mean,
Okay.
unless it's, I did it, 2 months ago or something, but generally not. It's not been a big issue. Following someone at high risk for, I mean, the reason why we doing these tests for patients who are at high risk for recurrence, and so if there's some issue regarding, whether it's even other more simpler blood tests, like changes in liver function tests or something, or anemia, can sort of justify that, or certainly any kind of symptom, fatigue, weight loss, whatever, those things can justify it. So it generally has not been a big issue. I think if we abused it, did like you're doing a PET scan every 2 months or something, I think you get some pushback there. But generally, if it's under reasonable situations, I would say no, there's not a problem.
Okay, thank you.
We have another question in chat that's looks like it's related to symptoms. I was diagnosed with rectal cancer at 52 years old. I had radiation and chemo, then a reversal. I'm having tightness on the bottom of my feet and legs that interferes with my gait. Eden, you may talk a little bit about different things. So did you all want to say something to that now or hold on to that?
I think we can answer it now. Yeah. Dr. Celano, did you want to?
No, you can. Why don't you go ahead and, because I'm
Okay.
sure you're familiar with these types of things,
Sure. So, Regina, I'm curious if the tightness, well, first of all, congratulations on being a cancer survivor because you're a survivor from the moment of diagnosis. So, congratulations on that. Yeah. And so the tightness on the bottom of your feet and legs, is that related to neuropathy, do you know? Or is that something unrelated to neuropathy? Have you been able to sort that out?
Neuropathy.
It is. Okay. So I'll let Dr. Celano speak a little bit to that as well, because I know that there's some there have been some emerging treatments for neuropathy, but also I think that you might benefit from some physical therapy that could certainly help help with your gait. And then there may be some medications. I'm going to let Dr. Celano answer that or touch on that if there's anything new out there for neuropathy.
Okay, thank you.
Of course.
Yeah, I mean, in terms of neuropathy can be a major problem for patients with colorectal cancer, particularly because of the drug oxaliplatin.
Mm-hmm.
And so that's, it can be very difficult to manage. There are certain drugs like Neurontin, gabapentin can be used. Sometimes drugs like Elavil can be used. Amitriptyline can be used in these settings. There are some interesting, actually at Johns Hopkins, Dr. Smith, I don't know whether Tom Smith at Hopkins has a program using this sort of, I won't call it biofeedback, but it's a kind of electrical thing. They actually published this in the New England Journal, which may be helpful to patients. I think we've actually referred them a few patients in this regard. But and I agree, physical therapy, you mentioned physical therapy, I think is important because I think everyone who's going through cancer treatment is somewhat deconditioned, and I think getting things moving and circulating can also be very helpful. Yeah.
Regina, our contact information will be provided at the end of the talk, and you're more than welcome to reach out to us. I am familiar with the study that Dr. Celano is talking about with Dr. Smith at Johns Hopkins, and I can certainly look into it for you if it's something that you're interested in.
Yes, I would be very interested in it.
Sure.
Thank
Okay.
you. Thank
Sure,
you
at
so
the
much.
end. Yeah, our contact information will be at the end, so be sure to grab that.
I will. Thanks again.
Of course. Any other questions for Dr. Celano that anyone can think of? Well, we'll have Q&A at the end as well, but I want to make sure that we don't leave any questions unanswered now. No? Okay. So Lisa, if you could go ahead and bring up my slides or continue with the slide. Yeah, thank you. So again, thank you all for being here with us tonight. Dr. Celano, thank you so much for your presentation. I learned something new every day, and I learned something new today. So thank you for everything that you shared with us. I'm sure others learned as well. I I am going to briefly tell you a little bit about my personal experience with rectal cancer when I was 26 years old. Next slide, please. So when I was a freshman in college, I have to think back a little bit. In 1989, I remember coming home over my break and complaining to, I think it was my primary care physician, that I had some abdominal cramping. And of course, I was a college freshman, so lifestyle changes were what my abdominal cramping was blamed on. So that was 1989, and I was at that time 18 years old, again, freshman in college. And I say that every 6 months I would go and I would see either my primary care physician or my OBGYN, and I would complain of different symptoms, whether it was abdominal cramping or diarrhea or constipation or fatigue. And again, it was just sort of poo-pooed. I was too young. Again, I wasn't familiar with my family history, and I'll share that in a bit. And I used to say that I would get my 6-month fix. That when I tell my story, that's what I say. So I was told one time, don't drink water out of a water bottle with a straw. You're putting too much air into your colon. Don't, work out. You've pulled a muscle in your abdomen. Do different, walk instead of doing the Stairmaster. Again, I called it my 6-month fix. And so I would do whatever I was told for 6 months, and then I would go back to the doctor, complain again. And this kind of went on until 1997, when I was living on the 3rd floor of an apartment building with no elevator. And I walked up 3 flights. I had just come from the gym, and I walked in to my apartment and I collapsed on the ground because I just couldn't take another step. I was so tired. And I remember pulling out my huge flip phone at the time in 1997 and calling my primary care physician and saying, something is wrong. This should not be happening. I just went to the gym. I can't, I went up 3 flights of steps and I can't take another step. So we have to figure out what's going on. Something is going on. So that led to an abdominal x-ray, which showed impacted stool. And that led to a colonoscopy, which without even having the pathology finalized, the gastroenterologist knew that it was cancer. That, of course, led to a CT. And then I had a low anterior resection followed by chemotherapy and radiation therapy. So at the time, instead of doing chemotherapy and radiation therapy up front, they did surgery up front. So again, I had surgery followed by chemo and radiation. And the only chemotherapy they had for stage 3 at the time was 5-FU. So that's what I got, 5-FU. There was nothing else offered. There was nothing else available. So to see that timeline that Dr. Celano presented with all of the new drugs and immunotherapy and targeted therapy, it just shows how far we've come since the late 90s, which is significant. So this slide just tells you a little bit. I had one diagnosis in 1997, stage 3B rectal cancer. I had 2 surgeries, one in 1997 and then a total hysterectomy in 2018, because the idea was that the radiation that I received, there was a high risk of secondary cancer from the pelvic radiation. So I had a total hysterectomy. I had 30 radiation treatments, 30 chemotherapy treatments, 24 colonoscopies and counting. If anyone has any questions about colonoscopies or preps, or they're fearful of it, I will talk you through it. I will drive you there. I will pick you up. I will make sure that you get that colonoscopy. So numerous blood draws, countless CT scans, multiple PET scans, 6 unsuccessful cycles of in vitro fertilization. Because when I had the initial surgery, they moved my ovaries out of the field of radiation to protect my ovaries, but we didn't realize the long-term impact that the radiation had on my uterus. And because I waited from 1997 to 2010 to try and use my uterus, we didn't know, the negative impact that it had on my uterus. So I wasn't able to carry a child. And then one successful adoption in 2013 after the 6 unsuccessful cycles of IVF. So that is a little bit of my story. And I mentioned, I want to go back to the family history piece because I had a very strong family history. As a matter of fact, I had a maternal aunt who passed away from colorectal cancer in her early 20s. And at the time, that they didn't really know what it was. And the more I asked my family members and the more I dug around, I learned that she actually passed away from colorectal cancer. So I say this because it's important for everyone here to know your family history as much as you can. And also to, when you're talking to your patients, to impress upon them the importance of knowing your family history. And if necessary, if there's a strong family history, of getting genetic counseling and then potentially genetic testing. So, and Dr. Celano talked a lot about genetics and the important role that they play now in diagnosis and of course in treatment. So next slide, please. So I want to talk a little bit about survivorship. Again, I mentioned that, the definition of a cancer survivor is you're a cancer survivor from the minute of diagnosis. I certainly believe that. I know that sometimes patients don't feel that way or don't buy into that idea. I try to impress upon them that from the moment you're diagnosed, whether you're going through treatment or where you are in your treatment trajectory, that you're a cancer survivor. So, and this idea of surveillance really applies to any type of cancer, not these specific tests, but there is an element of surveillance with any type of cancer once you are finished treatment, or even if you are, in indefinite treatment. There's an idea of surveillance. So that history and physical CEA, which Dr. Celano talked about, which is a crude blood test, but it is still used. Lab work, of course, just general lab work. And then for colorectal cancer, a CT of the chest, abdomen, and pelvis, and colonoscopy. And it's at different intervals for the first 5 years, and then typically not recommended after 5 years, unless, of course, there's a new symptom or something comes up that you feel like you need to investigate. There is certainly an impact on the quality of life when you're any cancer diagnosis, but colorectal cancer in particular. There's kind of this old school feeling that the shame of colorectal cancer, not wanting to talk about the bowels or rectal or colonoscopies, or the shame of the piece of colorectal cancer. But there's this physical impact, just like Regina shared with us, and thank you for sharing with us, the impact on your gait, the impact on your feet, on walking, on your bowels, on hands if you've got neuropathy in your hands. I mean, so many potential impacts on the physical quality of life from treatment. Then of course the emotional impact, the mental impact, depending on what your age is. I mean, I was a young adult when I was diagnosed, so I was dealing with issues of well, at the time I was engaged, but many young adults deal with the dating issues and sexuality and fertility and so many other, fear of recurrence and that what they call scanxiety, where the anxiety that comes along when you are going to, when you're about to get a scan or waiting for the results of the scan. So really a huge impact on the quality of life. And Dr. Celano mentioned a little bit about patients who need ostomies and whether or not they're temporary or they're permanent. I mean, that's a whole body image issue, body image concern. I know so many people that have lived full lives with ostomies, but until you have one and know what a full life you can live, there's a lot of fear involved. So that also has an impact on the quality of life. Next slide, please. A couple of other topics in survivorship: long-term side effects. And, I mentioned a lot of these. I can relate to a lot of these: GI problems, sometimes constipation, diarrhea, depending on what part of the colon was removed, uterine dysfunction, if there was radiation, vaginal stenosis. Again, that's a result of radiation, early menopause, fatigue, sleep difficulty. I talked a little bit about the fear of recurrence, anxiety in general, just related to the fear of recurrence, or just anxiety related to having gone through the treatment or going through the treatment, depression, negative body images, peripheral neuropathy, which we talked a little bit about, urinary incontinence, sexual dysfunction, difficulties with sexual health or intimacy. So these are all long-term side effects of the treatment for colorectal cancer and the treatment for other cancers as well, to be honest. A lot of these apply to other cancers. So, but these are long-term side effects. And I think, Dr. Celano showed that great slide about how many, there are 16 million cancer survivors in 2019, certainly millions more now. And so we have all these cancer survivors walking around with these long-term side effects, and we're learning more because guess what? People are living longer, which is great. But that also means that we have to stay on top of what the side effects could be and how do we treat them? How do we address them? How do we talk to patients about them? And also late-term side effects. So secondary cancers related to radiation is something that we also have to think about for any patient that's gotten radiation, but particularly abdominal radiation. I mean, we are certainly getting better with the targeted radiation, but when I had radiation, I had, it was a pretty big field that was radiated in my abdomen. So next slide, please. So this finding a primary care physician with knowledge of cancer surveillance. So again, because there are so many people living with cancer beyond the years that they are followed by a medical oncologist or a radiation oncologist or a surgical oncologist. Usually, and Dr. Celano can speak to this, it's the medical oncologist that's following the patients. And, it's hard to follow a patient for years and years and years and years. I mean, 5 years, okay, but then, again, cancer survivors are living longer. So 10, 15, 20, 25, 30 years. It's hard to follow patients for that long because patients are being diagnosed with cancer every day and they need to take on the new patients and treat the patients that are newly diagnosed. So at Hopkins in particular, we have a primary care program of primary care physicians that focus on cancer survivorship. And there's about 6 providers in the practice, and they mainly take patients who have a history of cancer, but a fairly remote history to the point where their cancer surveillance is not being directed by a medical oncologist any longer because they're that many years out. So, but if those aren't the only primary care doctors that are familiar with cancer because patients are being diagnosed and living longer. Many primary care physicians are familiar with cancer surveillance. But it is important for patients who are no longer followed by their medical oncologist that they find someone that has a knowledge of what could potentially be impacting them down the line. I talked already about the impact on relationships. Yep, next slide. That's good. And thank you to Dr. Celano for adding in this cancer.net. This is a patient education resource that is driven by the American Society of Clinical Oncology. And it's a wonderful resource. It's got a lot of information. I do refer patients to this all the time. Dr. Celano, did you want to say anything else about this website?
No, it's just a good general website for patients with cancer, family members, caregivers. There's also all kinds of links and information in that. There's other good websites too, but this is a really very up-to-date, reliable site. So we get a lot of good feedback from our patients on this who look at this.
I think you can go to the next slide, Lisa. Our contact information is here, Dr. Celano's and my contact information, and we wouldn't give it to you if we didn't want you to have it. So if you if you have any questions or want to reach out, please don't hesitate. We're happy to help in any way. And
Yes.
again, thank you all for being here tonight. Sorry, Dr. Celano, go ahead.
No, thank you so much. Thank you, Eden, and your story is just, it's very powerful. It makes me think of all the patients that we do deal with, and it's just, we talk about all these science and all these facts and figures, but it really gets down, it's what's happening to an individual person and how it affects their life and their relationships and everything. And it's just, it's so important for care.
Well, we couldn't, patients wouldn't be able to be treated if it weren't for physicians like you and research and everything that's going on. So thank you for all that you do.
And thanks.
Eden, there are a couple of questions in chat.
Yeah.
If you wanted
Um,
to.
Yep, I see. Yes, so any additional supportive resources you would recommend for young adult patients? Yes. So I would highly recommend the Ullman Foundation, used to be called the Ullman Cancer Fund for Young Adults. They have some amazing programs, a lot related to getting you moving and physical exercise and keeping you going after being diagnosed as a young adult, and also buddy programs. But yeah, that would be probably the biggest one. There are some young adult organizations that are disease focused, particularly for colorectal cancer. There's the Colon Club and Fight Colorectal Cancer, which merged into one organization. But the Colon Club is more focused on young adults. But again, they merge with Fight Colorectal Cancer. And then the Colorectal Cancer Alliance is for all ages, not particularly young adults. Yeah, Dr. Celano, any other young adult resources you can think of?
No, those are the big ones, and I'm very familiar with the Ullman Foundation and the great work that they do.
Yep.
But those are the ones you listed are the ones we tend to use as well.
Okay. Let's see. How do you relate to cancer patient as a cancer survivor? Well, sometimes I share my personal story if I think it would be helpful. And certainly I can, that's a point of relation. And I think, look, I think all oncologists and oncology nurses, it takes a special person to be one. You don't just have to be a cancer survivor to be, an oncologist or an oncology nurse. So I think there's always already that special piece. And I think I don't know that I relate to patients.
What's up, y'all? This is MC Light, and I
don't know if I relate to patients, I wouldn't say better. Maybe I just sometimes can relate to their side effects and, particular situations if they're going through in vitro fertilization. Sometimes people say, well, you can't relate unless you've been there. I think that depends on what you're talking about. So, yeah, but I certainly can, relate to cancer patients. Hopefully that answered your question.
Well, so this is Mercy.
Yeah.
So the reason I'm asking is I am a cancer survivor,
Mhm.
and I work in oncology as a nurse navigator, and I sometimes do share my story.
Mhm.
And it seems to, at times, in general, seems to make the patient even more comfortable
Mhm.
in talking with me.
Yes.
But I do understand where you're coming from. You have to choose who you disclose this information to.
Yeah. Yeah.
Sure.
I would agree with you, Mercer, that when I share, I 100% feel like it makes patients feel more comfortable, and sort of like, sort of less anxious, less, less anxious, I think. Yeah. So, well, congratulations to you on being a cancer survivor as well. Let's see.
Thank you.
Sure. How do you recommend we pursue genetic counseling? So I can certainly just give my 2 cents and then I'll hand this one over to Dr. Celano. I personally feel like it is very important that if you have a family history, that you talk to a genetic counselor before going through genetic testing, because there are implications for genetic testing that I feel only a genetic counselor can adequately cover. And just to prepare you for what the testing may tell you if you choose to, and really so you can make an informed decision of whether or not you want the genetic testing before having it. But Dr. Celano, I'm going to hand that to you as well. So.
Well, I completely agree that in general, we would say that patients should all talk to a genetics counselor if they're considering genetic testing and not just doing a sort of like a one-off test or something. And the indications for genetics screening has greatly broadened. Like, as you're aware, that for breast cancer, they've recently come out with a recommendation that all patients with breast cancer should have genetic testing, which is millions of people, and so it's something that I think we're going to struggle a little bit, because I don't think there's enough genetics counselors out there to handle that many patients. There's like at least 200,000 or 300,000 cases of breast cancer per year in the U.S. But it's becoming more and more broad. I think we're probably better, some kinds of newer like processes to do counseling and testing are going to have to be developed, because it's not just, it used to be for, as an example, breast cancer, you had so many first degree relatives with breast cancer and at so many ages and this kind, and there's a kind of a whole bunch of criteria, and it kind of whittled down to not that many people. Now, if you're saying anybody with breast cancer should have testing, that's a whole other situation in terms of the load of people. And then, we're all routinely doing like this mismatch repair analysis of basically almost every tumor that we take. And that's helping us to identify potential Lynch patients. And so it's a lot there. And so I think that the whole field has kind of exploded, but I think though, but in the end, it's going to be about hearing what this information is, like what's the right test. So the proper test is being done, and then how all that information is communicated to the patient and to the family, because the genetics is part of people's family. And so it's, how do you tell their siblings or their parents or their kids, and, and when are they going to get tested and all these things. It's complicated. Okay.
Eden, I have a question. You've gone through a lot of through your journey of having to go back and advocate for yourself to make sure that folks heard you. What can you suggest, or what do you suggest that people say in order to advocate for testing and for people to take their symptoms seriously?
Yeah, that's a great question, Yolanda. And you know what I tell people? If a doctor doesn't listen to you the first time, go find another doctor. Simple as that. That's where I'm at. That's where I stay at now. I mean, it should be one and done. You complain of a symptom, it should be, well, I say if it's longer than 2 weeks, that's what I say. If you're experiencing a symptom longer than 2 weeks, you should look into it and figure out what is going on and advocate for yourself. It's not easy. It is not easy. I mean, I see it wasn't easy for me then. Obviously, I mean, it was 8 years. I my older self would tell my younger self that was, 8 years too long. But it's hard. It's not easy to find a doctor that's going to listen. But there's a bunch of navigators on this call, and you just have to. Navigators can help you navigate. Talk to your friends. Have friends help you. Just advocate for yourself. That's what I would say. And there's not only one type of doctor out there for each discipline. So if they don't listen, find another doctor.
Thank you.
I agree more. Definitely, there's no shame in advocating for yourself.
That's right.
And for your family member, if that's, sometimes that's our role too, to advocate for our families or friends. But it's, people have to be listened to, and things have to happen. Right.
If there are any more questions, we do have more time. If anybody has questions, feel free to take yourself off mute. and you can ask a question. If you're more comfortable putting it in chat, that's fine as well.
You mentioned this is Pam. You mentioned the clinical trials and the opportunities there. Any thoughts on recommendations for patients in terms of how they pursue understanding clinical trials and advocating for themselves for clinical trials?
I think as part of any question people have in terms of when they're being told a diagnosis, almost anything, but cancer in particular, I think the question of, and it certainly occurs to me as I'm seeing patients, is there a clinical trial that's available for this patient that may be of benefit to them? I mean, sometimes the clinical trials, there aren't necessarily something that exactly fits them for all kinds of reasons, but I think that whole thought process needs to occur with basically every patient. And if anything, even when patients decide they hear about a clinical trial, they decide not to do it, I find it's a great educational tool that people can read about something and understand, well, what is that issue and what are they trying to do? And even if they decide that's not really what I want to do, at least it becomes something that they become much better informed and knowing something, maybe it's not useful now, but in the future it may very well be.
Thank you.
Eden, your experience with that, with you and your patients.
Yeah. Yeah, I would agree. I mean, I think, we're all in that mindset in the oncology world of thinking if there's a trial available for a patient and maybe if it's not at our institution, there's ways of looking to see if there's trials available at other institutions.
True.
Yeah. Yeah. And I think, I think there's, some myths out there about clinical trials that you only go on them when you're the last ditch effort. But there are plenty of patients who actually start on a clinical trial, do great on a clinical trial, and then move on. So I think that, I think it's, yeah.
Important question.
I can share one patient's survival story on that. I had 17 years ago, I had stage 2B colon cancer and went through surgery, of course. After that, they told me, well, there's an 85% survival rate, but we have this research program that you can become involved in that where goal is to cut that by 25%. Okay, so I did it, and the rationale that I used was if I don't do it and it comes back, I wish I had. And if I do it and it comes back, I've got a right to complain. But in any event, obviously it's 17 years ago. It's something worked, so that's just fine by me. And the next part of that question is, I am now 88 years old, and I heard the doctor give a rationale for why they stopped the colonoscopies, and I'm not sure I understand exactly why, but it's okay.
Yeah, well, the rationale has to do with that the number one, the cancers would have developed by then. It also honestly goes into morbidities. Patients as they get older can have other issues regarding, heart disease and lung disease and things that make colonoscopies more risky, because there is a risk for colonoscopies, not without its risk, and certainly that risk is higher in elderly patients. So that's the rationale. But that being said, for any individual, that may mean absolutely nothing. They may be vigorous. They may feel this is worth it to me, and they go ahead and do it. Yeah. And certainly if they have symptoms, I will say that doesn't mean that if a person who's 88 years old has bleeding or change in bowel habits or cramping or whatever, that they should have a full, they're otherwise healthy. They should undergo an evaluation, and that could very well include a colonoscopy.
Well, I'm a great whiner, so if that happened, I would be complaining to someone.
Yeah. Good.
Thank you for
Good for
your
you.
Thank you for sharing your story.
Thank you.
Hey, it looks like that is it. We want to thank Eden and Dr. Celano for sharing all of that great content. I don't know about you, but I took some notes in my phone, and I'll probably go back and listen to the recording. Please watch your emails. You will receive a survey along with the recording probably within the next week or so. We'd love to get your feedback. Take a couple of minutes just to fill that out. It really helps to develop more presentations like this for other audiences. Thank you. Yes, Pam also placed into chat that the recording of this session will be available on the OFMDC website. Please check the website also for previous sessions like this that you can go back and watch as well. And before we close out, any other thoughts, questions? OFMDC YouTube page. Maybe soon we'll have Pam on TikTok, or something like that. Yeah.
I don't know. It has to be around, right? I do have one last question that I meant to ask, and I apologize. With this recent news and public publicity surrounding younger people being uh, diagnosed, or more younger people being diagnosed, do you see any changes that will happen there in terms of screening? I mean, we still have it at 45. I don't know. Should we be promoting for younger screening, or is it, you mentioned family history and genetics would be a really good,
Well, the
really good
drop
tool to have in your hand.
the drop from 50 to 45 was in response to that very
Was it
well.
okay?
That was, but I mean, could people have you screened sooner? Certainly patients that are in patients with strong family histories and those concerns, I think, are there. And of course, also as Eden's story, I think, is, this disease can show up, or these types can show up in anybody, really, and so just because you're 20 years old, it doesn't mean that this isn't something that should be checked out. But
Thank you.
I wouldn't ever be, but it would not be for the average 20-year-old, but patients with symptoms or family histories or concerns like this surely should be checked.
Yes.
Thank you. Thank you both very, very much. This really, really excellent and informative conversation. As Yolanda said, I know I learned a lot. And I'll go back and watch it again and learn more, and then I'll watch it again and learn more. So thank you.
Well, thank you for giving us the opportunity to speak to this group. And
Yes,
this is very, I always find I learn a lot too in these types of presentations.
yes, I second that. So thank you all for having us.
Yeah, and thank you to all of the folks who shared and felt comfortable enough to share their stories tonight and give us feedback as well. That helps a lot. I think that we can wrap it up for the evening, but please again look out in your emails for the recordings and the surveys. Thank you. Have a good
Thank
night.
you.